Welcome to this explainer. Today, we're going to unpack the absolutely critical metrics that medical professionals rely on to assess brain injuries. We'll be taking a journey from the simplest ways we measure human consciousness all the way to the incredibly high-stakes, split-second decisions made in the back of an ambulance and inside trauma wards. It's a fascinating leap from basic field assessments right into some intensely complex clinical debates.
Okay, so let's dive right into this with a pretty heavy question. At what exact second does a brain injury become so severe that a machine actually has to take over your breathing? There's this bold clinical warning, GCS less than or equal to 8 equals intubate. And that rule is really at the heart of our discussion today. To truly understand it, we're going to explore the famous Glasgow Coma Scale, or the GCS. It's literally the universal tool used by medical professionals all around the globe to measure human consciousness.
Here is our roadmap for today. We're looking at the Glasgow Coma Scale, EMS and baseline scoring, the intubation threshold debate, decorticate versus decerebrate posturing, and finally, prognosis and takeaways.
All right, Section 1, the Glasgow Coma Scale.
So the most crucial thing to grasp here is that the Glasgow Coma Scale provides a universally understood language. When someone suffers a traumatic brain injury, healthcare workers, from the very first responders on the scene to the neurosurgeons in the OR, they need a rapid, totally objective way to communicate exactly how severe that injury is. Subjective guesses? Yeah, they just don't cut it in trauma medicine. The GCS solves this by assigning a hard, numerical value to a person's level of consciousness. To picture how this works, imagine a friendly, 3D Pixar-style cartoon robot trying to teach this to kids, and on its chest are 3 glowing icons, E, V, and M. Those are the 3 pillars of the assessment. E is for eyes, meaning your eye-opening response. V is for voice, which is your verbal response. And M is for motor, looking at your physical motor response. If you're a perfectly healthy, conscious person, you're going to score 15. The lowest possible score? That's a 3, which indicates a deep coma.
Moving right along to Section 2, EMS and baseline scoring.
Long before a patient ever sees the bright lights of an emergency room, the assessment has already begun. Picture a warm-lit, realistic scene of a paramedic checking on a patient in the back of a moving ambulance. They use the GCS right after the trauma happens to establish a critical baseline. And this initial field score is absolutely vital. Why? Because whether that number goes up or down before they even reach the hospital is a massive predictor of survival. If a patient's GCS score drops during transport, it's a huge red flag to the receiving hospital that the brain injury is actively worsening, maybe from swelling or bleeding, and it allows the trauma team to prep for immediate, life-saving intervention.
Now for Section 3, the intubation threshold debate.
Imagine shifting from the ambulance into a professional, highly clinical 3D hospital ward. There is a stark, widely accepted warning in emergency medicine. A score of 8 or less means intubate. It's a classic medical mantra. Official guidelines say that at a GCS of 8 or below, a patient's consciousness is so decreased they typically can't protect their own airway. That means they're at a really high risk for aspiration and their breathing might be compromised. So doctors step in with rapid sequence intubation, using medications and paralytics to secure the airway and prevent any secondary brain injury from a lack of oxygen.
But wow, here is where the science gets incredibly compelling. As impartial observers, we're just looking at the data here, but the contrast between those traditional guidelines and some brand new research is striking. While established global guidelines mandate intubation at 8, recent studies are actually pushing back. Research shows that immediate intubation for patients with a score of 7 or 8 who have isolated head injuries was independently associated with higher mortality and more overall complications. In fact, one recent study found that intubating at any threshold above a 5 resulted in longer ICU stays and more complications. The data suggests that a GCS of 5 or less might actually be the true threshold where intubation confers a benefit without making things worse. It's a fascinating debate, and it's asking the medical community to tailor their practice instead of just relying on a one-size-fits-all number.
Okay, Section 4, decorticate versus decerebrate posturing. Beyond the numbers, we have to look at the physical manifestations of severe brain damage. When the brain is under extreme duress, the body can involuntarily assume 2 critical postures. First, we have decorticate posturing. This is abnormal flexion. The arms slowly flex at the elbows and wrists, drawing inward to the chest, while the legs extend. Anatomically, this usually means there's damage higher up in the brain, above a structure called the red nucleus. Then, there's decerebrate posturing, which is abnormal extension. The arms extend straight out and pronate, and the legs extend rigidly. This one is significantly more ominous. It signals a much deeper, highly destructive lesion descending right into the brainstem.
Now these terms can be tricky to remember, so let's use this fantastic mnemonic from the YouTube channel Registered Nurse RN. It is brilliantly simple. To remember this stance for decorticate posturing, just think of the word itself. The patient pulls their arms to the core for decorticate. Simple, right? And for decerebrate, look at all the letter E's in the word D-E-C-E-R-E-brate. Use those E's to remember extended, because the arms are abnormally extended outward.
Understanding these postures is just absolutely critical. This timeline tracks the grim progression of central brain herniation. Basically, as pressure inside the skull forces the brain downward, the patient's neurological status predictably gets worse. They move from the diencephalic phase into decortication. Then, as the damage reaches further down into the midbrain and upper pons, the posture shifts to decerebration. Finally, if that immense pressure reaches the lower brainstem, the medulla, the patient becomes completely flaccid. So recognizing that shift from flex to extended arms tells a doctor exactly how far the damage has progressed downward.
Finally, Section 5. Prognosis and final takeaways.
These statistics underscore the absolute gravity of the situation. Abnormal posturing is always an ominous sign. Following a severe head injury, patients displaying that flexed decorticate posturing have roughly a 37% survival rate. But if the injury progresses down the brainstem and they shift into decerebrate posturing, that survival rate plummets to just 10%. Furthermore, if a patient's GCS motor score stays below a 4 after a full day post-injury, the research shows there's virtually no chance of them ever regaining functional independence. It's a really sobering reminder of just how incredibly delicate our central nervous system truly is.
So I want to leave you with this final provocative thought to wrap up today's explainer. We've seen how the Glasgow Coma Scale gives healthcare workers a universal language, and how physical posturing maps the harsh reality of brain damage. But as new research challenges that classic intubate at 8 rule, suggesting it might sometimes actually do more harm than good, it begs a massive question. How do we perfectly balance rapid, aggressive medical intervention with the body's own natural limits? It's a profound reminder that emergency medicine isn't just about rigidly memorizing old rules. It is a constantly, rapidly evolving science striving to save our most vulnerable minds. Thanks so much for joining me, and as always, keep questioning the data.